If you haven't had a chance yet to log in, please go ahead and log in. You'll see a pretest and some elements to fill out there, which we would really appreciate your participation with. Throughout the program, there will be opportunities for you to respond to ARS questions, as well as the opportunity for you to claim credit and ask questions of our esteemed faculty here this evening. So we would like to encourage both the virtual audience at home as well as the in-room audience to submit those questions using the Ask a Question button at any time. And as time allows, our faculty will, of course, respond. So we are grateful that you're all here. And without any further ado, I'll turn it over to Dr. Camilleri and wish you all a great program. Thank you.
Thank you.
Thank you. Thank you. Good evening, all, and welcome to this evening symposium, Maintaining the Momentum in the Treatment of Chronic Idiopathic Constipation, Framing Practical Clinical Strategies Through Case Studies. And this is an education program that's supported by an educational grant from Takeda Pharmaceuticals USA. So in support of improving patient care, CME Outfitters LLC is jointly accredited by the ACCME, the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. So you can follow us on Twitter at CMEO Outfitters for the upcoming CME CE opportunities, healthcare news, and more. I'm Michael Camilleri. I'm Atherton and Winifred Bean Professor of Medicine, Pharmacology, and Physiology at Mayo Clinic in Rochester, Minnesota. Lucy?
Hello, I'm Dr. Lucy Harris. I'm an Associate Professor of Medicine at Mayo Clinic in Scottsdale and do motility from stem to stern. But today I'm concentrating on stern.
And I'm Brooks Cash. I'm Chief of Gastroenterology and Professor of Medicine at the University of Texas Health Science Center in Houston, Texas. I was in the Navy for 24 years, so I like the stern analogy, so thank you.
Well, our learning objectives tonight are first, to accurately diagnose chronic idiopathic constipation, differentiating it from irritable bowel syndrome with constipation. Second, to evaluate the characteristics of therapies used in the management of chronic idiopathic constipation. And third, to develop a comprehensive treatment strategy for patients with chronic idiopathic constipation, constructed from evidence and clinical guidelines. Lucy?
So I'd like to impart to you that this is really a very common problem and affects about 11 to 13% of adults in the United States. And patients do endure symptoms for often greater than a couple of years. This is a disorder that affects women and the elderly disproportionately. And interestingly, when we did our burden study that looked at chronic constipation, we actually found that only 30% of the population that we interviewed actually sought care. But you can see from this slide that there is, from that 30%, that has a great economic impact with a lot of patient visits, a lot of direct medical costs in terms of drugs and visits. And then patients also seek care in the emergency room, and those ER visits have accumulated to greater than $1.6 billion. Excuse me. And then constipation impacts quality of life. You know, we can't just think of this as a disorder of, well, it's just constipation. Because again, when we looked at the burden study, we found that 60% of the patients actually found that this interfered with their personal activities for 4 days per month. A quarter of the patients actually missed almost 2 months of work or school per year. And we should also remember that patients don't like talking about bowel habits, and it induces a lot of shame and embarrassment, and they're frustrated when they come to us. And so they are often reluctant to discuss their bowel habits, and this requires us to be a little bit more inquisitive in terms of asking them about symptoms.
So let's look at a patient case. Dina is a 45-year-old female with a 3-year history of constipation. She's referred to the gastroenterologist by her primary care physician. She reports having 1 to 2 bowel movements per week, straining with 50% of her bowel movements, and having a sense of incomplete evacuation about 70% or more of those bowel movements. She has daily bloating and discomfort, though she denies significant pain. She also denies melena, hematochezia, or weight loss. Her past medical history includes obesity with a BMI of 30 kilograms per meter squared, and 2 children born by vaginal delivery. Her current medications, she takes daily Docusate, 200 milligrams 3 times a day, PEG 3350, 17 grams once daily, and Bisacodal orally 1 to 2 times per week. That's usually the 5 milligram tablet. Magnesium citrate solution is used as a rescue if she has no bowel movements for 5 days. Her symptoms are impacting her quality of life. She's missed work 6 times in the last 3 months. She works as an elementary school teacher. She's worried that she's in danger of losing her job. She's exhausted with trying to manage her symptoms, and she feels like her life's focus is on managing her bowel issues. So this is where we're going to ask you to let us know what you think is going on. So based on the available information, can you tell us what is the most likely diagnosis for Dina? Is it chronic idiopathic constipation, irritable bowel syndrome with constipation, a rectal evacuation disorder, generalized intestinal motility disorder, or I'm not sure, I need more information? Let's have you vote your responses. Okay, Dr. Harris, Dr. Brooks, Cash, tell us what you think about these responses.
I actually agree with the response. I think I'm not sure either. I need more information, so I think I would vote E. I think that the others are certainly possibilities, as we'll learn about. I'm glad not everybody got fooled into the title of the symposium, just choosing CIC. We didn't give you complete information on purpose because that's what we're going to talk about in the next section as Lucy goes through the diagnostic criteria, and hopefully all will become clear.
Yes, so I agree with that as well. So diagnosis presents a lot of challenges for us. There are, it's a fluctuating disorder, so it's oftentimes difficult to diagnose. There are no available biomarkers like there are for inflammatory bowel disease. And oftentimes when you see patients, you find that patients have undergone colonoscopy, but no one's really addressed the symptoms in detail. And there's a lot of anxiety around the symptoms. And I still think that from a patient perspective, there is not a lot of knowledge about all of the treatment options. And sometimes even providers don't always go and delve into all of the treatment options. So I think let's take a look at the Rome criteria for functional constipation. So this diagnosis, let's be honest, it's not something that we necessarily go to clinically, but it evolved because we needed to have a good definition of constipation for clinical trials for medications. So functional constipation is defined as less than 3 defecations per week, and it has to include greater than 2 of the following, greater than a quarter of the time. That's straining, lumpy or hard stools, feeling or sense of incomplete evacuation, a sensation perhaps of anorectal obstruction, or the use of manual maneuvers. And you should remember that loose stools actually are rarely present without using laxatives, and patients really meet insufficient criteria for irritable bowel syndrome, meaning they don't have a lot of pain. Symptoms also have to be chronic, so they should be there for at least 6 months prior to diagnosis, and the criteria that I've just discussed have to be there for at least 3 months.
We have an interesting question here that comes from the audience. Do we have any idea why chronic idiopathic constipation is more prevalent in women than in men?
Well, I think that some of the theory is that they might be more likely to have pelvic floor dysfunction. There may be some hormonal influence as well. I think those are the theories that I've heard the most.
Yeah, and I think the other thing that we need to recognize, and we'll talk about this a little bit later, is the concept of rectal evacuation disorders. And that is more common in women. There are numerous reasons why that situation can arise, and some of it is inherent, and I think probably you get this history from a patient where they've had very long-standing, described constipation as a child, that, for lack of a better term, the potty training just didn't take. Some of it is acquired, and we have to think about some of the experiences that our female patients, as well as our male patients, have had in their lives. Sometimes those are some delicate situations. You need to establish that therapeutic relationship with patients, but asking about sexual abuse and trauma is also incredibly important when we are talking about these types of disorders, whether we're dealing with what we think is chronic idiopathic constipation or irritable bowel syndrome with constipation, or even other constipation syndromes.
And I think we also should remember women do seek care for this disorder. So in real life, differentiating constipation-related symptoms is a little bit more complicated. The Rome Foundation has evolved this little picture that actually shows us that patients can alternate in their habits. Bloating and distension may be components of all of these disorders, and patients flip back and forth. The Bristol Stool Scale that's shown there demonstrates a scale that actually correlates fairly well with transit, with the harder type 1 and type 2 stools correlating with slower transit. So let's talk about some of the key history components for constipation. So as I alluded to, you really need to ask the patient, what is your most distressing symptom that you're having? Do you get relief of your symptoms with defecation? An important question, as we've already kind of alluded to with evacuation disorder, is there prolonged straining? Is the patient sitting on the toilet or using unusual postures to have a bowel movement? Do they do anything to manually remove the stool or press on the perineum? Or do they have a problem when they use an enema that they are unable to expel the fluid? Also, you want to ask patients about their bowel habit. Do they feel an urge to have a bowel movement? Do they go to the bathroom? Do they leave themselves enough time to go to the bathroom? And I find it helpful to do a dietary history, and if you don't have enough time because you have a 15-minute office visit, then actually maybe using some kind of questionnaire that looks at diet is extremely important, because the average American doesn't have the 20 to 30 grams of fiber that's required. I don't know, Brooks, did you have any other thoughts?
Yeah, there are a couple other things that I will tend to ask, and one is the duration of symptoms. How long have they had these constipation symptoms? I alluded to it earlier. Has this been 20 years of constipation or difficult defecation, or is this a new onset condition? And if it is a new onset set of symptoms, especially if patients are older, then we do need to think about secondary causes, asking about their other medications, doing a complete medical history, and making sure that they're not on medications that can cause constipation. And Lucy alluded to it a bit in terms of the toileting behavior. One of the key questions I ask patients is how long they're sitting on the toilet. And it's amazing when you get these stories. I take a book in there and I'm there for 30 to 45 minutes, and I exhort them not to do that. That fatigues the perineum. It's not a good situation for them to do. So I tell them no more than 5 minutes, and really that's pushing it, not to make a pun, but then get up, walk around, and heed your next call. Finally, I will ask them about alleviating factors. If they exercise, do they exercise? And if they exercise, does that help? Are there any things that they can do that seem to ease their symptoms or promote a satisfactory bowel movement?
I asked the question about the duration of being in the restroom in a different way. I ask patients, do you have a library in your restroom?
Yeah.
That's a more subtle way of perhaps saying, do you need to use a book and read for a long period of time?
Right.
So we have a couple of other questions that I think are quite interesting. We've already alluded to the greater prevalence in women, but can we talk about age and can we talk about race? Are there different racial prevalences in, that we know from the literature, and age?
Yes, I alluded to it earlier that elderly are disproportionately affected by constipation. Also, I think the African American population has also been shown in the literature to have problems increased problems with constipation. Those may be diet related too. So I think that's another reason why asking a dietary history is particularly important.
We have some other questions which we're going to address in the next few minutes, related to things like squatty potty and resistance development with docusate treatment. So let's move on to consider key history components in chronic constipation in terms of treatments.
So Dr. Cash has already alluded to asking about current and present medication use. And if you use EPIC, you can actually create a little, I have this in my EPIC record, sort of DOT therapeutic trials, and I go through a list of medications, and it's a quick yes/no kind of thing where you can actually get a little feedback on what they've tried and what their response has been. You can also ask about rescue medications and enemas. And one of the things that we really need to address with our patients is the actual cost. They get prescription medications, and then they come back and they tell us, well, I haven't tried that yet. And oftentimes it's because of the cost. So I think finding out about cost barriers is particularly important as well.
That's a wonderful point because, again, a question has arisen as to whether we have any advice or any considerations about helping patients with insurance to cover the costs of medications. But let's get back to thinking about those symptoms of constipation. Is that just infrequent bowel movements?
Well, as this study nicely demonstrates, bowel movements less than 3 times a week did affect about 3/4 of the patients, but a significant proportion of patients, greater than 90%, complained of straining during defecation. Another 60 to 70% had hard or lumpy stools or incomplete evacuation. Only about half of patients actually complained of anorectal blockage, and a smaller percentage actually only used manual maneuvers. I think it's also important to look at a few other components in history, which we'll do in the next slide. So I think you're all familiar pretty much. You've seen this slide probably multiple times about red flags, but it's still important to remember that unintentional weight loss is an important historical component. If patients are over the age of 50, that's more unusual sometimes to have these symptoms of constipation, although there is some slowing of the intestine with age, but it should also bring to light making sure patients have undergone their colon cancer screening. You want to check about family history of things like inflammatory bowel disease. Even celiac disease can present sometimes with constipation. Rectal bleeding is an important indicator. It may indicate something more than just straining at stool. On your physical exam, you should be keyed into looking for an abdominal mass. You should be doing a good rectal exam. We'll talk about that a little bit later. And then there are things on imaging and laboratories, particularly things like thyroid function, that may be red flags.
So what might be potential secondary causes of constipation?
So secondary causes of constipation I find are, primarily I think medications are a big one that we need to look carefully at when patients come to us. We've already alluded to colon cancer, but ovarian cancer can present with a change in bowel habit and bloating, so that's important to keep in mind. Collagen vascular disorders can present with constipation. Another big one for me is I check about history of Parkinson's and multiple sclerosis. We've alluded to metabolic disorders. Some patients come with a big history of surgeries, so mechanical obstruction may be playing a role in their constipation. And then there are central nervous system disorders, or even things like pseudo-obstruction that may also be causing constipation.
So I got to tell you an anecdotal story here. I was in my second year on staff, and I saw a patient with constipation in the clinic, and I did a biochemistry group and a serum thyroxine and TSH. And I found this patient had a serum calcium of 13 milligrams per deciliter. Normal is to about 10.5. And I was so pleased. I went to speak to my former mentor. And I said, isn't this amazing? Did an ultrasound of the neck, found a parathyroid adenoma. Isn't that amazing? I said to Dr. Phillips, who's passed away a few years ago. And he said to me, Michael, you never need to worry about that for the rest of your career. You'll never see another parathyroid adenoma presenting with constipation. And he was right.
Which is why he was your mentor.
Yeah.
Right, exactly.
Okay, so let's see whether we can ask you to give us some more feedback here. What's the most appropriate next step in determining a diagnosis for Dina? Is it to order a colonic transit study, anal rectal manometry and balloon expulsion test, a CT scan of the abdomen with IV contrast, perform a digital rectal exam, or I don't know? Brooks, would you like to tell us what you think about this?
I think I agree with the audience. This is an important aspect of the evaluation of patients with the symptom of constipation, as well as to make the diagnosis of chronic idiopathic constipation, and even for that matter, irritable bowel syndrome with constipation. Constipation really should have a digital rectal examination. And the opposite extreme, incontinence, same thing. So we'll talk a little bit more about this in a second, but I agree, that's the right test to do right now.
Dr. Harris, any reaction to the results that we're seeing here?
I totally agree. I emphasize this with all of my fellows and medical residents that I see, and I know we'll talk more about the digital rectal exam, but it's so important.
We have a question about why are we thinking about Parkinsonism in somebody presenting with constipation, and we don't have time to go that into great detail, but of course some of the medications are anticholinergic. L-DOPA slows down the colon, and also patients with Parkinson's disease also have evidence of myenteric plexus degeneration, and they may also have a rectal evacuation disorder. So that's not quite idiopathic constipation, it's secondary, but we have to keep it in mind, especially in older patients. What about the subtypes of constipation?
Well, I think this is very important. As a motility expert, I try to convey to patients, sometimes we get stuck with just thinking about whether this is a transit issue. And, about 2/3 of patients actually do have normal transit, but about 1/3 of patients can actually have slow transit in a tertiary practice. A very small percent of them, or actually slow transit is really 5%, I misspoke, and a third of patients have a rectal evacuation disorder, which highlights the importance of actually doing that. So slow transit is really a very small part of what we see, but we need to think about it because it could be a myopathic or neuropathic defect. And I think we also need to think of rectal evacuation disorders beyond dysenergic defecation, which is kind of the inability to relax pelvic floor muscles. In my population, I see a fair number of Ehlers-Danlos patients, and those patients can actually have too much descent of their pelvic floor muscles. And you can also remember that having a bowel movement also involves coordination of the abdominal muscles as well as the ability to produce propulsive forces in the rectum.
So what are the pearls in doing a digital rectal examination?
Well, I'll take this. And, you know, Lucy alluded to it a second ago with regards to pelvic floor descent. So even before we get to the digital rectal examination, it's important to position the patient in the appropriate way, and that should not be standing up and leaning over a table. That should be laying down on the table on the left side generally, depending on where the bed is, but ideally they should be on their left side. And you want to have the patient bear down. You want to do an external evaluation, look for lesions around the perianal area, test for sensation, make sure there's an anal wink as well. And then you want to have the patient bear down, and you want to observe how much perineal descent they have. It should be about 2 centimeters. That's the general average. And as she mentioned, there are some conditions where there could be too much. There's some conditions where there may be too little. Then we're ready for the digital rectal examination. The position of the hand that you see there on the far left is important, and the way that you have the ball of the index finger pointing towards the posterior aspect. You gently insert that. You ask the patient to squeeze before you even advance your finger. And again, this is not pleasant for the patient. It's not pleasant for the examiner, but it's a critically important aspect of this examination. If on insertion, the patient is incredibly tender and you need to be thinking about a fissure, you may need to abort the examination and have them either see a colorectal surgeon or do an exam under anesthesia. That's a little bit extreme, but think about that. I'd probably empirically treat a fissure first and then try to bring the patient back. But ask the patient to squeeze and see if you get a good squeeze there. Then you insert the finger more deeply and you try to feel that puborectalis muscle, and you can see where that's located on that posterior aspect, and that's why it's so important to have the hand position as shown in this picture, because the sensation in terms of the examiner is better in that aspect. Again, ask the patient to squeeze, assess if there's tenderness, if you can feel that muscle contract, and then have them try to push your finger out. You ask them to simulate expulsion of the finger and look for paradoxical contraction as well. So that is a good digital rectal examination, the way it's supposed to be done. It does take practice, but as you practice this and you do it more and more, the more adept you will become at feeling normal versus abnormal. And there is actually a relatively good performance value with regards to this examination. In fact, that's shown, as we'll show on the next slide.
So before we do that,
sure.
Let me just give you another pearl.
All right.
Okay, so sometimes when you're looking for the degree of perineal descent on inspection, the patient is reluctant to really push because, especially women, are a bit shy of the possibility of farting in my face. But when you have your finger in the anal canal, they feel more secure. This is all patients. And you can get a better assessment of the degree of descent. So that's another thing. And if you have puborectalis spasm, dysynergia, your finger is going to be pulled up instead of being pushed out. So that's another clue. If you don't see much descent on inspection, check it also with your finger into the anal canal. So how good is the performance of digital rectal examination?
Well, it is pretty good, and here's some actual data to support that statement. So these are patients who had chronic idiopathic constipation according to the Rome 3 criteria. Now, that was a little while ago. The Rome 3 criteria were not dramatically different from the Rome 4 criteria, and I dare say we probably won't see a huge difference even in the Rome 5 criteria, which are being worked on now. But about 200 patients with criteria meeting chronic constipation. And this was a study looking at the sensitivity, the specificity, More importantly, I think even the positive predictive value and the negative predictive value of a digital rectal examination. And again, the goal here is to identify that 30% of patients that have dysenergic defecation. And as Lucy so nicely showed on the slide where she was talking about the subtypes, and it was a bit of a subtle picture, but what you hopefully noticed in that Venn diagram with those circles is there was overlap between the rectal evacuation disorder and normal transit or the rectal evacuation disorder and slow transit. So you can have overlap in terms of these etiologies. So this can be part of the picture, and that's why it's so important to identify it. But you can see the positive predictive value, I'll hone in on that, 97%, 0.97, I'm sorry, in terms of that estimated positive predictive value. So very useful if it is abnormal on your examination. Not as useful if you don't pick up on that abnormality, but that's why practice makes perfect and why we need to do more of these examinations in patients. But this can be a very useful test, and it is a physical exam skill, just like feeling the thyroid and doing other physical exams and listening for murmurs that I can never catch when I was training. But the more you do this, the better you will get.
So this really addresses a couple of comments we've had. One comment was, I'm finishing residency, we don't do digital rectal exams. Not sure they're effective. I think these data from Satish Rao's study really address that question. And another question was, how do we keep up the practice of including rectal exams in the evaluation of these patients from becoming a thing of the past? And you've really articulated the importance of doing that. What about other testing, whole gut transit studies?
So we do have these studies, and it's important to realize that I recognize when I'm talking to you about them that they're not available everywhere. Scintigraphy is only available in about 3 to 4 centers in the United States. We can do gastric emptying study at a lot more places. Scintigraphy is good for gastric emptying and actually for colonic emptying, but it's not so good for the part in the middle, and that's important to recognize, because if you do have a patient who's undergone this study, the part in the middle may not be as reliable. Wireless motility capsules are available, but oftentimes they're difficult to get covered by insurance. Patients eat a standard meal, and they actually, there are different numbers of days that you actually keep the pill or keep track of the pill. So if you're looking at gastric emptying, it's 3 days. If you're looking at colonic emptying, it's 7 days. For small bowel motility, it's 5 days. And it can be very helpful for patients who have small bowel and colonic motility problems. Probably the one thing I would keep in mind for gastric emptying is that it's a pill and it's not quite like food, so it can kind of a little bit overestimate, I've found, gastric emptying. There are also a couple of other tests that we had. You are probably all familiar with the markers that you swallow. There are a couple of different techniques that are utilized to use that. Usually it's pictures on day 4 and day 7. We use it to identify slow transit constipation, but you have to pay attention to that figure on your right that correlates wireless motility capsule findings to the radio-opaque markers. You can see that there are a lot of outliers for slow transit constipation, and what the marker study doesn't take into account is actually the effect of having a pelvic floor dysfunction problem. So you can't really tell whether a patient has slow transit until you've ruled out a rectal evacuation disorder. And that you can also not just figure out with anal rectal exam, but also with anal rectal manometry, which is a balloon test. You can also look at emptying via defecography, via barium study, or an MRI study. Personally, I like the barium defecography because I think it's a little bit more physiologic, because the patient is actually sitting on a commode, whereas in the MRI study, they're doing the defecation in the lying down position. An advantage there can be that you can actually see some of the pelvic structures a little bit better.
Let's move on to treatment. So Dina's current treatments consist of daily medications, Docusate 200 milligrams 3 times a day. We mentioned PEG 350, 17 grams in 8 ounces of water, bisacodyl 5 milligrams once or twice weekly, magnesium citrate solution as a rescue if there's no bowel movements for 5 days. And she's currently having 1 or 2 bowel movements per week with incomplete evacuation, straining, and bloating. Her previous medications have included probiotics, daily bowel health supplements have been tried, but there's been no improvement. She has not had any previous prescription use. On physical examination, the abdomen shows palpable stool in the right lower quadrant of the abdomen and the left lower quadrant. Rectal examination, there's normal perineal descent during straining. This is both on inspection and on palpation. There's normal anal tone at rest, which increases the pressure of the sphincter with squeeze. No paradoxical contraction is noted, no puborectalis tenderness, and no masses, fissures, or hernias are noted. So first of all, does this tell us anything about the possibility of excluding a rectal evacuation disorder based on those performance characteristics of the digital rectal exam?
Right. Now remember that study, which I didn't go into in terms of where it came from, but it came from an expert center, Satish Rao's center. And remember that negative predictive value was 0.37. So even a negative rectal exam doesn't completely exclude a rectal evacuation disorder, but it does make it less likely. So again, I would never say never, but at the same time, I'm thinking more along the lines of perhaps delayed transit, more likely normal transit, because that's just playing the odds. But I think it's less likely that she has a rectal evacuation disorder, but it should always be in the back of your mind, and I often will back into that diagnosis based on our patients' responses to therapies.
So at the present time, let's ask you, the audience, another question. So what would be your treatment recommendation for Dina? Increase the Docusate, add soluble fiber, schedule bisacodyl daily, 5 milligrams orally, start a prescription prokinetic or secretagogue, or I don't know. Let's have your responses, please. Dr. Harris, let's have your reaction to this response.
I think this is a good decision, and I'm glad to see that we didn't recommend increasing the Docusate. So I'm very encouraged by this.
Okay, well, one of the questions we had was, can people become resistant to Docusate? And I know we're going to be discussing that in the next few slides.
Yes. So let's look at over-the-counter treatments for chronic constipation. This study by Brian Lacey nicely demonstrated that almost 3/4 of patients had tried at least one over-the-counter medicine. Another 20% had tried greater or more than 3 over-the-counter medications. And what I would like to call your attention to is that very few patients actually persisted in using medications on a daily basis. Perhaps the most used on a daily basis was the PEG. And patients didn't persist in using medications for greater than 6 months. Maybe about half of the population did, and it's pretty amazing that they persisted in using stool softeners. And you look at the reasons that patients discontinued medications. They discontinued them for abdominal symptoms and for the fact that they really didn't work for bowel symptoms. And so let's take a look at the deal with Docusate with the next slide. So there's been a few articles lately that have really pushed back on the use of Ducosate. I mean, you know, you send your patients for surgery and practically all of them come back with a recommendation that they should take stool softeners. But really, Colitis doesn't help. It can maybe soften a stool, but it's really not a medication for constipation. And you can see the American College of Gastroenterology Chronic Constipation Task Force actually said that stool softeners have minimal, if any, effect to improve the symptoms of chronic constipation. So along with the myth of Ducosate, I would also like to dispense with the myth that Senecot causes, or Senna causes problems with constipation if you use it. That's my other favorite old wives' tale that I'd like to get rid of.
We have a comment here. All of our hospital orders have patients on Docusate. Are you saying it's wrong? What do you think, Dr. Cash?
Yes. You know, and again, in the context of chronic idiopathic constipation, there is very little evidence to support its use. Now, when patients get admitted to the hospital, we do a lot of things, and I love these articles, the myth of the month, and things that we do for no good reason. You know, we put patients on stool softeners, we put them on PPIs, often for no good reason, and then they get discharged on those medications, which then leads to polypharmacy and costs of care. Now, these are not terribly expensive medicines, but at the same time, there are some concerns about things with this. So yeah, I think that there's not a great reason to be putting patients on these therapies. Now, if you're going acutely on a opioid therapy, then absolutely, I think a stool softener can be very helpful. But for just getting admitted to the hospital on those order sets, I think is not the correct thing to do.
So let's start thinking about the potential for prescription medications for constipation. And can you tell us a bit more about the mechanisms of action of these different drugs?
Sure. So I'll take this section, and we're going to start up in the upper left, and we'll start with the over-the-counter therapies, and specifically what we call bulk-forming agents or bulking agents. The other word for that is fiber. And you can see how those agents work. They basically create a mucilage. They hold on to bile acids. They hold on to fat. They accumulate water. They make the stool somewhat softer. They also bulk up the stool, and they cause some distension, which may cause, in turn, some release of other neurotransmitters and perhaps even some additional motility. And that's how those agents work. Now, if we move down below that, more over-the-counter therapies. Some of these are prescription therapies as well. We talked about bisacodyl and senna. These are irritating laxatives. The other word for that is stimulating or stimulant laxatives. They cause irritation of the enterocytes and release of neurotransmitters, which also can accelerate transit. That's one of the reasons why people often will have crampy abdominal pain with these types of therapies. Also on that lower left portion are the osmotic laxatives, polyethylene glycol, lactulose. We use lactulose a lot for our patients with chronic hepatic disorders and hepatic encephalopathy. PEG is the most widely used therapy for not only acute and short-lived constipation, but also chronic constipation. We'll show you some data with regards to that. Those osmotic laxatives really cause water to be held in the gut, and can draw some water into the gut as well, and those can produce very effective laxative effect, but they can also produce a somewhat uncontrolled or excessive laxative effect as well. And then we'll move over to some of the more prescription or typical prescription agents that have been recently FDA approved, and there are a whole host of therapies to choose from. And we'll highlight some of the differences as we move forward with these therapies in terms of not only their indications, but also their mechanisms of action. But the things that I would want to really highlight is that most of these therapies work by causing fluid fluxes across the gastrointestinal lumen. So the most widely used therapies these days in terms of chronic constipation would be the secretagogues. And there's really three secretagogues. Lubiprostone, which was the first. You see that kind of in the middle of the slide, right on the enterocytes there. Remember, that opens up a type 2 chloride channel, and that causes chloride and then sodium and water to move into the gut lumen. We also have the GCC agonists, and those are linaclotide as well as prokinetide. And as their name suggests, they are agonists at the guanylate cyclase C receptor. That causes a cascade of events in terms of accumulating cyclic GMP and creating some ion fluxes, which again accumulates active secretion into the GI tract. GCC is one of the primary motivators in our gut in terms of causing active secretion. You all are secreting and binding to your GCC receptors right now because you just ate a meal. We also have the prokinetic agents, and we left one off this slide. This is my fault, but those are prucalopride and tegaserod. So tegaserod was left off the slide inadvertently. These are 5-HT4 agonists. In the case of tegaserod, it's also 5-HT3, has some 5-HT3 activity. And these are promotility. We like to use the word prokinetic as opposed to promotility, but promotility is a much more descriptive term, and they increase contractions. And then finally, the newest addition in terms of our prescription therapies that are FDA approved would be tenapanor. You see that at the very bottom. This is an agent that causes, it's a sodium hydrogen exchanger isoform type 3 inhibitor. Try and say that 5 times fast. What that does is it blocks sodium absorption, and it causes sodium to accumulate in the gut lumen. That traps water and also facilitates defecation. I'm going to show you clinical data on all of these therapies in just a moment.
Thank you for that summary of all the pharmacology. Now, let's start with fiber supplementation. How do we use this? Soluble, insoluble, how much?
So I think that using fiber supplementation may have a very important role in a proportion of patients who really are not getting fiber in their diet. Soluble fiber is usually better tolerated. Some forms of over-the-counter fiber contain a combination, like Metamucil, it's a combination of soluble and insoluble fiber. Patients who have a lot of gas and bloating or maybe slow transit, however, excuse me, are not good candidates for using fiber, and I think that's important to realize. So if patients have delayed colonic transit or dyssynergia, fiber may have a limited role, but in the patient who you think is not getting enough dietary fiber, I think it's a useful thing to actually start with.
Thank you. So, Brooks, you already started indicating these medications and the mechanism of action.
Sure.
Can you tell us a bit more about the doses and summarize this information?
Yeah, no, I alluded to this a second ago. We've got some differences with regards to indications. I won't go back through the mechanism of action. We've already handled that. But just to familiarize you with the doses as well as the FDA-approved indications for these agents. So we'll start at the top, prucalopride. Remember, that's a 5-HT4 agonist, so it's a prokinetic therapy. Tegaserod would fit into this same category, but prucalopride is approved for chronic idiopathic constipation only. Now, one of the questions that often comes up, I'll head this off at the pass, is why are these approved for one versus both or both? Well, it's an FDA decision based on the studies that were done and presented to the FDA. Same thing for some of the specifics with regards to the patient populations, and I'll get into that as we talk about the individual therapies. The dose of prucalopride is 2 milligrams once a day. Then we have the secretagogues. Those are all approved for both IBS-C as well as CIC. Lubiprostone, linaclotide, prokinetide, chloride channel activator, 2-GCC agonist. In the case of lubiprostone, it's only approved in IBS-C for women. Again, I'll get to that in a second. It's because the studies were done in primarily women. You can see the doses there of lubiprostone, 24 micrograms twice a day for CIC, 8 micrograms twice a day for IBS-C. Those were the doses that were evaluated in the phase 3 trials that were done for FDA approval. That's the dose the FDA approved for those indications. Same thing for linaclotide with regards to its 2 doses for CIC, 72 or 145 micrograms once daily, 290 micrograms once daily for IBS-C. For prokinetide, it's easier. You just have to remember 1 dose, and that's 3 milligrams once a day. And then tenapanor, the newest agent that's on the market for IBS-C only, because those are the only studies they've done thus far. 50 milligrams twice a day, and Tegaserod, the other prokinetic agent, just IBS-C in women, 6 milligrams twice a day. So those are the doses. Hopefully that's a helpful table for you all when you decide to use these therapies.
So these are costly drugs. Can we talk about the cost efficacy, the implications of prescribing these medications?
Yeah, we certainly can. And these are, as Dr. Camilleri mentioned, these are often perceived, both by patients as well as clinicians, as costly drugs, and certainly by third-party payers. And you can see some of the costs that are associated in terms of annual costs for these agents. This is a very nice study done by Eric Shaw. And what he really showed here, and this is really the message of this study, is despite the costs, we actually see an improvement in quality of life, and we see an actual cost saving with the effective use or the benefit that patients are deriving from these therapies. And again, this is using really a lot of the clinical trial results and extrapolating that into what would be a theoretical real practice. But the bottom line that this slide really is meant to convey is that in appropriate patients, when these agents are used appropriately, they actually turn out to be cost effective, because these patients are decreasing their healthcare resource utilization. They're not going to the emergency room. They're not coming to see the doctor as often. They're not getting additional, usually unnecessary and invasive and expensive tests. So at the end of the day, when we look at these therapies, it's kind of analogous to some of the strategies that we've bandied about for colorectal cancer screening for many years. They're actually cost effective because they are effective therapies.
That's a very wonderful summary. Thank you. So let's go through the pharmacology of each one of these medications, and we have a number of very interesting questions which we can address at the end of the session. Lubiprostone.
Yeah. So let me run through at least the clinical trial data with regards to lubiprostone. There'll be a little bit of mix and match, because we are going to address some of the therapies that have an indication for IBS with constipation as well. But again, lubiprostone approved for both indications. This is a non-absorbable GI-targeted bicyclic functional fatty acid, another mouthful. It's a chloride type 2 channel activator, essentially. That's what we mentioned earlier. There's also some evidence that it may actually even help restore the integrity of tight junctions and intestinal permeability, and have an effect on intestinal pain or pain that we believe is resulting from that. The dose for CIC we've already talked about. The major adverse events that we see with this agent would be diarrhea and nausea. You see nausea up there at the top. These were the rates that were observed in the clinical trials for CIC. And it's important to mitigate that side effect by taking the medication with food. This is something they discovered after these studies were done. When these studies were done, lubiprostone was administered in a fasting state, and we saw high rates of nausea. What they found out later on was that when patients took this with a decent, normal-sized meal, that nausea rate was significantly lower. Here's the clinical trial evidence from the 2 pivotal trials that were done with lubiprostone. Compared to placebo, you see the endpoints there. At least 3 complete spontaneous bowel movements per week. That term often confuses people. It's a regulatory term, but you can also imagine what it means clinically. This is a bowel movement without the use of a laxative or any other laxative other than the investigational therapies here, in which the patient feels completely evacuated. So it is a high-quality, complete evacuation. And remember, we talked a lot about that sense of incomplete evacuation that's so bothersome to patients, and it's one of the criteria for chronic idiopathic constipation. The other study here by Barish looked at more than at least 4 complete spontaneous bowel movements per week. Numbers speak for themselves. Nearly 60% response rate with lubiprostone at that dose of 24 micrograms twice a day, significantly greater than what was seen with placebo. If we move on to linaclotide, remember this is the first GCC agonist that was FDA approved. It stimulates secretion of intestinal fluid. It mimics really the natural effects of several peptides, guanylin and uroguanylin, that we all release. There's also some evidence based on animal models that it helps reduce abdominal pain as well. That's one of the reasons why it gained an IBS indication based on the trials that were done. For CIC, the 2 doses that are FDA approved are 72 micrograms and 145 micrograms once daily. The major adverse event that was seen in the clinical trials with Linocletide were diarrhea, abdominal pain, flatulence, and distension, with diarrhea really taking the lead. And if we look at the clinical trials here, there's actually 3 studies. Now, this also incorporates some data in terms of IBS-C patients, but when we look at the 3 different doses, and in the CIC studies, the chronic idiopathic constipation studies, they did look at the 145 microgram dose as well as the 290 microgram dose, and there wasn't much difference. You can see that depicted in study 2 and study 3. And that's why the FDA approved the 145 for CIC. If we were going to look at the IBS-C studies, we would see there was actually, when they looked at, they didn't look at both doses, but there was a statistically significant benefit with the 290 microgram dose. Because of the diarrhea side effect, they investigated even a lower dose. That's the 72 microgram dose. You see that in study 1. A little bit out of order in terms of what were, when these studies were done chronologically. And you can see that the 72 microgram dose was really essentially as effective as the 145. In clinical practice, the thought is that perhaps if we do run into some diarrhea, we can titrate down on the dose, and we may be able to mitigate that for our patients. Now, so the other important thing I want to bring out with these studies is look at that endpoint. These are different than what were looked at with the lubiprostone studies. So it makes it inherently difficult to compare these drugs head-to-head based on these data. In this case, what was used as the endpoint was the current regulatory endpoint that the FDA requires. At least 3 complete spontaneous bowel movements per week, and an increase by at least 1 over the patient's baseline, and in this case for more than 9 out of 12 weeks. That's a high bar to reach. That's not what we measure in clinical practice. We ask patients if they're satisfied, if they feel better, are they happier, are their symptoms relieved? We use all these vague kind of global terms. The FDA doesn't like that. It's hard to measure. It's very different from patient to patient. So think of when you see these results, one of the first responses that patients or that an audience may have or clinicians may have is, well, that's not very effective, 20% response rate. But you have to consider what the endpoint is, and what we see in clinical practice is significantly higher than that.
What about the other GCC agonists?
Well, it's a very similar story. Now, the difference between Prokinetide and Linocletide is the thought that Prokinetide, which is really a very similar analog to uroguanilin, binds to that GCC receptor in a more acidic environment. And if you think about the GI tract and the gradient of the pH in the gut, it's lowest in the stomach. Acid is highest in the stomach, so lowest pH in the stomach, and gradually approaches 7.4 as it moves down towards the colon. So this is primarily thought to be binding to these receptors in the small bowel as opposed to the entire GI tract. And the thought is that perhaps it's allowing the colon some time to reabsorb some fluid, and maybe there's less diarrhea with this agent compared to other therapies. Now, you can see the side effects. We do see diarrhea as the most common adverse event in the clinical trials with regards to Prokinetide. If we look at the results of the 2 pivotal trials that were done with this agent for CIC, again, the dosing here is 3 milligrams once a day. This endpoint here was similar to what we just looked at with regards to Linocletide endpoint, and what you see is a statistically significant difference compared to placebo. The numbers are not all that dissimilar. Again, none of these agents have been compared in many ways head-to-head, but I think what we can say is you get a similar effect and there's clear efficacy compared to placebo.
So you've covered beautifully the secretagogues. What about the prokinetics?
Okay, so the prokinetic that's approved for CIC right now is prucalopride. This is not a new agent. It's new to us. We've had it for a couple of years. It's actually been approved in 60 other countries for greater than 10 years. And many of us used to write for this from Canada or other countries when we had the access to that. So this is remember this is a 5-HT4 serotonin type 4 agonist. So it accelerates gut transit. It actually accelerates high amplitude propagating contractions. There is also some evidence that it may stimulate secretion as well. The dose that we've already went over is 2 milligrams once a day. There is an alternative dose, a lower dose that you can use in patients with renal impairment. I also tend to, in my own practice, if I have a octogenarian or an older patient who's significantly bothered, we've tried other things, we've made the decision to go to this, I may use a lower dose in those patients as well. You can see the adverse events here. This is actually more of a class effect. We saw this with the other serotonergic agents as well. Headache, abdominal pain, nausea, and diarrhea. Now, some of these adverse events are quite transient. So if they do occur, what I often will tell patients is try to stick with this agent for a week, and oftentimes some of those adverse events may attenuate. The other thing to recognize with regards to prucalopride is that it's been extensively studied and evaluated, in fact, by Dr. Camilleri, with regards to cardiovascular events. That has been a concern for some other serotonergic agents, and that does not appear to be any signal for cardiovascular safety issues with regards to prucalopride. There is a warning in the label that you need to be aware of, and that is with regards to, and again, another class effect, with regards to worsening depression and suicidality. Doesn't appear that there's a significant signal. In fact, that when you read the warning, the FDA explicitly says there is no obvious causal or relationship, but because there were some suicidal attempts and actually some successful suicides in these studies, that did make its way to the label.
So you mentioned these high amplitude propagated contractions, and tell us a bit more. What do they do?
Yeah, so this is a really important aspect of thinking about prokinetic therapies. And there's different terms for these high amplitude propagating contractions. It doesn't trip off the tongue. We don't use this in our clinics. But think of this as basically squeezing the toothpaste tube. And that's the way I describe it to patients. And when we talk about pelvic floor dysfunction, I'll say I can squeeze that toothpaste tube really, really hard, but until I take the cap off, I can't get the toothpaste out of the tube. The high amplitude propagating contractions are the squeeze. And they occur in a cephalad to caudad direction. They're basically these coordinated periodic contractions, ideally greater than 50 millimeters of mercury in a top to bottom conformation. They're stimulated by meals. There's a phasic activity and then a meal-stimulated activity. And what prucalopride does and what other serotonergic agonists do is it increases not only the frequency of these squeezing contractions, these coordinated contractions, they also increase the strength of these contractions. And that's probably why we see such a beneficial effect. In fact, if you look at this graph on this slide, this is actually one of the very few comparative studies that we have between laxatives, in this case prucalopride versus PEG 3350, not looking at symptoms, but looking at the physiologic effects. And you can see clearly that prucalopride stimulates those high amplitude propagating contractions, whereas PEG, an osmotic laxative, doesn't seem to do much at all. And that might be one of the reasons why some of our patients don't respond as well to polyethylene glycol.
So are the effects of prucalopride consistent in the literature?
They are. So there have been, as I mentioned, this has been approved in 60 other countries for more than 10 years, recently made its way to the US and got FDA approved. And interestingly, that approval did not require any new studies. So these studies that are shown on this slide, there's been 6 studies that have looked at this agent for chronic idiopathic constipation. This is a very nice summary article that Dr. Camilleri published, and actually now almost 7 years ago, really summarizing these studies. And you can see that consistency. There was one outlier study, we don't know why, that did not show statistical significance between placebo and prucalopride. One of the things, if you dive into that study, that was seen was a really pretty high placebo response rate that seemed to attenuate that delta between investigational therapy and placebo. But the rest of the studies, very consistent results. You can see both in men and women with regards to that endpoint, which was in these studies, because they are older, more than, at least, I should say, greater than or equal to 3 complete spontaneous bowel movements per week. I think I may have said even day. I'm thinking back to what I was talking about with lubiprostone. It's per week. If I said per day, I misspoke. But per week in terms of stimulating that laxation. And a really very consistent response with regards to prucalopride.
What about the other 5-HT4 receptor agonists?
Okay, that's tegaserod. Now, not many of us probably prescribe a lot of tegaserod. I have a handful of patients on this agent. This is an agent that was around for a while that went away, and then it made its way back. And one of the reasons it went away was because of that concern about cardiovascular safety. This is a 5-HT4 agonist. It also, as I mentioned earlier, had 5-HT3 activity as well. It has a restricted indication, and that's why we don't use this agent that much. It's indicated only in women less than age 65 with one or fewer cardiovascular risk factors. The reason for women is because that's the predominant population that was in these studies. You can see the risk events or the cardiovascular warnings there. The dose is 6 milligrams twice a day. Typical side effects that we saw with the other serotonergic agent: headache, abdominal pain, diarrhea. Nausea also can fall in there. In terms of efficacy, this agent is primarily, right now it's approved for IBS-C. It was once upon a time approved for CIC, but upon its re-release, it was just released for IBS with constipation. You can see the benefit here in terms of the comparison of placebo in two studies, one by Michael Kam and the other by John Johansson. Again, older studies, but clearly effective. Similar mechanism of action of prucalopride, increasing HAPCs, some effect on secretion, some effect on pain as well.
Well, earlier we talked about secretagogues, and in the table we didn't classify tenapanor as a secretagogue because it really affects the sodium-hydrogen exchange. It changes the absorption, if you will. That's why it's not called a secretagogue. But how efficacious is this in IBS-C?
Yeah, well, you know, we're just starting to get used to this agent. We just got approved 2 years ago, just got marketed in April of this year. So I've written for it a few times. Just to introduce you to this agent, it's a minimally absorbed small molecule that blocks sodium absorption. It traps fluid in the lumen. And it's not a secretagogue for that reason. Secretagogues imply active secretion of fluid. This is more of a passive retention of fluid. It's different than an osmotic laxative as well because of the way it works. The dosing, as I alluded to earlier, 50 milligrams twice a day. And the studies that they did to gain approval were in patients with IBS with constipation. Main difference being significant abdominal pain associated with constipation. And that's what really defines IBS primarily. There's a couple of other subtle differences, but we won't get into that right now. If we look at the clinical trials, Bill Shea actually published 2 studies, both in the American Journal of Gastroenterology, one in 2020, another one in 2021. These were known as the Tempo 1 and the Tempo 2 trials, if I'm not mistaken. And their endpoint was an improvement in abdominal pain by at least 30%, as well as an improvement in complete spontaneous bowel movement frequency that exceeded 3 for 9 out of 12 weeks. So similar to some of the other endpoints that we looked at. You can see the results there. The combined endpoint, really near about 3 times the effect compared to placebo for tenapanor. There was a statistically significant improvement in pain, as well as a statistically significant improvement in complete spontaneous bowel movements. So time will tell in terms of what we see with this agent in the clinic and what its place is in therapy for these patients.
So we've told you about a lot of the medications that are available for chronic idiopathic constipation, and you may be wondering, is there any way to compare the relative efficacy of these medications? And one way in which you can do that, because there are very, very few, if any, head-to-head comparisons, is to compare the effect of each one of these medications to placebo, to see how much more efficacious they are relative to placebo, and then put them on this sort of forest plot or league table, I like to describe this to my students, that tells you a little bit more about the odds ratio of being efficacious for the treatment of chronic idiopathic constipation. So in this systematic review meta-analysis by Alex Ford's group, there was an attempt to see whether the medications help with the more than 3 complete spontaneous bowel movements per week for 8 to 12 weeks in the clinical trials, which was the simplest common denominator, if you wish, of these different trials. And what you can see there is that the top benefit came from the treatment with prucalopride at 2 and 4 milligrams. And as you move down the league table, you can see the efficacy of the other medications. These are all medications that are approved in the United States, except for elobixibat, which is a bile acid transport inhibitor that induces more bile acids to get into the colon and cause secretion. And that's approved in Japan, not approved in the United States. But this gives you some semblance of what is the relative efficacy, but we have to still state there are no head-to-head comparisons that really give you the opportunity to be accurate in your assessment of the relative efficacy. So, we've covered a lot. We have some wonderful questions which we'd love to get through in the question and answer period that we're dedicating at the end of this presentation. But what are some myths and misconceptions regarding chronic idiopathic constipation?
Well, this is actually from an article that I was lucky enough to collaborate with Kyle Stoller on. And what we did with this article is we published this in the Red Journal a couple of years ago. We had a little time on our hand because of the pandemic. And we revisited a classic article by Arnie Wald and Mueller-Listner from, I think it was 10 or 12 years prior, that was entitled Myths and Misconceptions About Chronic Constipation. And it was just an absolutely beautiful article. I encourage you all to find that and read it. We decided to try and update that, and not necessarily with the same myths and misconceptions, but even some different ones. And so I'll walk through these pretty briefly, because we've touched on a lot of this. The bowel movement frequency is the most important part of the chronic constipation complaint. Absolutely not true. I think Lucy clearly showed straining, hard lumpy stools, sense of incomplete evacuation. Much more important, those somatic symptoms to our patients. CIC and IBS-C are distinct conditions. No, there's a lot of overlap. I just mentioned a second ago that pain is the major differential factor. But we see patients at different points in time who could fit either criteria. Now, there clearly are some patients that we will end up diagnosing with IBS with constipation, and they are clearly IBS with constipation patients. Pain is their predominant symptom. It distracts them. It limits their life. There are other patients that are much more in the middle, and you can have pain and discomfort with chronic constipation. Colonoscopy. There really is no role for colonoscopy in patients with chronic idiopathic constipation. And I'll say that with some caveats. Of course, you have to address the alarm features. So there is a role in somebody who says that they have a metachesia. There's a role in an older patient, in this case, older being now 45. So 45, well, I guess it's, 50 is the new 45 or vice versa. So anyway, we're all becoming more and more obsolete. And it's getting younger and younger. But colonoscopy doesn't have much of a diagnostic role for chronic constipation. We showed clearly that it's not very much due to delayed transit. Bloating is a common symptom. It's not unique to constipation at all. It crosses many barriers. Lifestyle changes, drinking a lot of water, that's another absolute myth. And I hear this from patients all the time. I drink 20 cups of water a day. I just need to hydrate more. It really doesn't do much. There's one study that showed that it can help older patients who are in nursing homes who probably have some baseline dehydration, but in an ambulatory younger patient, drinking a lot of water is just going to make them urinate more. Fiber, Lucy covered how fiber is not created equal. A daily treatment goal or daily bowel movement is the treatment goal? No. If the major complaint is straining and a sense of incomplete evacuation and hard lumpy stools, those are the treatment goals. That's what patients are bothered by. And then finally the role of surgery, which should really be minimized. This should be no more than 1%, hopefully a lot less than 1%, only for very select patients. These are going to be our colonic inertia patients that just don't respond to anything, perhaps also with a pelvic floor dysfunction on top of that. So a very small group of patients that should go to surgery. You will get those patients in clinic that say, I just want my colon out. Their quality of life is actually going to be lower. It's not the right thing to do.
Thank you. Dr. Harris, how are we going to integrate care?
Well, I was just thinking about this. You know, I practice in a tertiary setting, and I'm lucky enough to have all of this in one center. You know, I have a dietitian who's a GI dietitian. I have now a GI psychologist. We have plenty of gastroenterologists, and we even have a physical therapy program. I was fortunate enough to hear a little presentation from Dr. Bilche earlier this evening, And he made the important point that we all have to work to achieve integrated care. And you may think to yourself, well, I'm in private practice, how do I do this? And there are more and more resources for this. So there is now a GI initiative to have kind of online dietitians that's facilitated by our GI societies. There are online behavioral programs that you can tap into as a private practitioner. Physical therapy may be a little bit more challenging because I don't know how to do that via virtually. That does require a little manual contact, but there are folks out there. So I think that really needs to be our goal. Also, dysenergic defecation. We need to have physical therapists and biofeedback for those patients. There have been many studies that have shown that that can improve bowel habit function up to 70% in patients. It's quoted anywhere from 30 to 70%. And so it can increase both the bowel movement frequency, the use of manual maneuvers, decrease straining, and decrease feelings of incomplete evacuation. So I think we're going to share some take-home messages.
All right, let's do that, and we're going to leave some time for questions. So we wanted to make the point that we can distinguish IBS-C from chronic idiopathic constipation, and this actually could help the treatment. And the main differentiating symptom is the abdominal pain component in chronic idiopathic constipation, irritable bowel syndrome with constipation. Chronic constipation is common, it's debilitating, it can cause a significant cost, impacts quality of life. The initial therapy usually consists of the over-the-counter treatments. Patients often try these prior to seeking medical care, but they're often, unfortunately, ineffective or incompletely effective, and there's evidence-based prescription medications that should be considered. Chronic idiopathic constipation, the medications approved are lubiprostone, linaclotide, prokinetide, and prucalopride. IBS with constipation, lubiprostone, linaclotide, prokinetide, as well as tenofovir and tegaserod. And we can continue to consider further diagnostic testing if there is no response to prescription therapy or if there is the presence of alarm features. And one of the questions that turned up is if you have patients with Parkinson's disease or you have patients with spinal cord injury, for example, what is the role of using the prescription medications? They may not have been specifically tried in those patients, but certainly it appears to me that if the patient has not responded to the first-line treatments, it's perfectly appropriate to treat with the diverse medications that we've discussed tonight. So the SMART goals, specific, measurable, attainable, relevant, and timely. We can accurately diagnose both chronic idiopathic constipation and irritable bowel syndrome with constipation. We need to recognize the value of a positive diagnosis of these conditions using judicious and limited diagnostic testing. There's a question about the cost of transit measurements, and of course, radiopaque marker transit measurement is by far the least expensive, and it's really quite accurate for identifying slow transit constipation. The presence of alarm features should prompt further direct evaluation. Of course, that will most often involve colonoscopy. We need to initiate evidence-based prescription treatment options for chronic idiopathic constipation and IBS-C in patients who are failing treatment with lifestyle modifications and over-the-counter options. And we need to understand the potential advantages of a multidisciplinary approach, the integrated approach to care in these patients with more severe refractory symptoms of chronic idiopathic constipation or IBS-C. So we're going to ask you to continue to send us questions. To submit a question, please go to the Ask Question tab at the bottom of the screen. We also remind you that you can visit the Gastroenterology Hub of CME Outfitters. There are free resources and education to educate healthcare professionals and patients on chronic idiopathic constipation. You see the HTTPS, the logo that you need to put into your search. And to receive credit, you can receive CME or CE credit for this activity. Participants, we ask you to please complete the post-test and evaluation online, and then you can click on the Request Credit tab to complete the process and print your certificates. So we want to thank you for your involvement, for your participation. And we have a number of questions here, if we have some time, that we'd like to try to address. So, okay. First question, how helpful is psychotherapy and cognitive behavioral therapy for chronic idiopathic constipation compared to, let's say, how helpful it is for irritable bowel syndrome with constipation? Dr. Harris, can I throw that curveball to you?
Well, I think that points to the fact that people, flip between the two. So I think that really depends on the amount of, anxiety that you sense that the patient has about their condition or about, just their stress level in life. But I would imagine that it would pretty much approach what we see in IBS with constipation, because they're, as I said, they really flip between. So
yeah, and I'm a big proponent of some of these psychological therapies, and the three that rise to the top are cognitive behavioral therapy, gut-directed hypnotherapy, and mindfulness meditation. Psychodynamic psychotherapy, which is the traditional lay on a couch, and the way I think of them, kind of the those of you that are old enough to remember Bob Newhart, it hasn't been as widely studied. But they deal with the here and now. They reframe the patient's way that they deal with the symptoms. So it doesn't really dive into their past experiences. And many of the studies have looked at the functional GI disorders as a whole. They're not necessarily subtyping patients into irritable bowel syndrome, functional dyspepsia, chronic idiopathic constipation. So I absolutely agree with Lucy's assessment. I think it's likely just as effective. It's a really important aspect of care. I think you have to ask your patients if they're willing to do that, if they're motivated to do that. Sometimes they'll tell you themselves, stress seems to bring on my symptoms, it makes it worse, I notice it's worse when I'm stressed out. That gives you a way, an in to talk to them. I view it very much as adjunctive therapy. We're going to have to kickstart their GI tract and get them to have effective bowel movements, but it helps them deal with their symptoms in many ways and really reframe their experience and stop catastrophizing and focusing on their symptoms, because it can become a vicious cycle. So it's a great aspect of care.
I'm going to take the next question, which was, does prucalopride help with constipation from opioid medications? Now, it's not an approved indication, but there is actually one small randomized controlled trial from Europe that actually demonstrated that prucalopride does relieve the constipation in patients who have opioid-induced constipation. Next question. So how long after you start these medications, these different medications, let's say prucalopride and a GCC agonist, how long does it take before you really start to see a beneficial effect of treatment?
Well, I tell patients to really be patient with their treatment, because they may start out with being very constipated. So, I know there are some practitioners who actually suggest to patients that they should do some kind of colon prep before they begin these medications. I don't necessarily do that. But I do urge patients to give the medication at least several days, and to, before we start adding in other things. And I usually say 2 weeks. Let's, get back to me in 2 weeks and let me know how things are going.
And actually, if you look at the long-term open-label studies with many of these medications, it's actually exactly what you just said.
Right.
Often there's this flush-out effect. So as soon as it works, you'll often see 6 or whatever complete spontaneous bowel movements per week, and then it stabilizes again at about 4 or 5. But there might be that first flush-out effect of the effect of the medication. So that's what I tell my patients as well. It usually is in a couple of weeks' time. Okay, can these medications be combined?
They certainly can. I will often use, in patients who have a partial response, let's say I'll start with a secretagogue, and then I may add in a prokinetic therapy, or vice versa. So it's all, it really is all in listening to the patient, following the patient up, and asking them, how much better they are, and if they're satisfied with their therapy. And of course, we're going to ask them about their symptoms. I use over-the-counter therapies with some of the Prokinetics as well. So I'll use an osmotic with a prokinetic therapy. I don't tend to use the secretagogues with the osmotic laxatives because the mechanisms to me are very similar. So it's usually a prokinetic plus some other class, and that's what I'm doing when I combine therapy. Now, when I have patients who are not responding to therapy, for instance, I'll start a secretagogue and the patient comes back and says, it didn't do anything, or a prokinetic, it didn't do anything. Then I'm starting to think more aggressively about testing them for pelvic floor dysfunction, because I do think that failure to respond to medical therapy is a predictor for pelvic floor dysfunction. Some of my colleagues will do that testing right off the bat. The way I think of it, if it's 30%, I like the go where the money is principle, so the Sutton principle. So I go where the money is and I treat empirically first and then test later.
So, Dr. Harris, you mentioned that there are online tools for identifying dietitian and biofeedback. I think that unless you know this off the top of your head, we might have to answer that question through CME Outfitters later on.
Right.
Next question, is there a high incidence of ischemic colitis in IBS and CIC? The question is IBS rather than...
There's not a high incidence, it's a rare condition, but there is a higher incidence in IBS. And this actually came about because of the experience with Elocitron, which is a therapy for IBS with diarrhea. And one of the things that was found with Elocitron, this is a anti-motility agent, so it's a serotonergic antagonist that puts the brakes on motility. One of the adverse events, there was another drug called Cilancitron, which showed the same thing, same mechanism, same events, rare events of colon ischemia. Severe constipation was the most common adverse event, but colon ischemia did occur, and it was, I think, pretty definitively shown that there was an association. It was rare. That drug went off the market. It now is available again. It's a very effective therapy in a very select and carefully curated group of patients. I have a few on them, or quite a few actually, on Elocitron with chronic diarrhea, and it works very well. It's not my first-line therapy. It's my third or fourth-line therapy. So there is a relationship, but what was found when we went back and did analyses was that IBS did seem to predict for, was associated with colon ischemia. There may be some confounders there, the greater likelihood in women. There's possibly other medications, so it's hard to control for those. It's much like the PPI data and trying to find harms with PPI. There's probably some confounders in there that we're not aware of.
And again, the epidemiological study done in California actually had demonstrated that IBS per se is also a risk factor for the development of ischemic colitis. So your comments are very well taken. Next question. Which time of the day is it better to prescribe these drugs? Should they be taken in the morning, in the afternoon? My patient often asks me, how long does it take for the drug to stimulate the bowel movement? So can we help the patient know when their bowels are going to work so that they can do their social or work activities?
I think I tell patients that, I'm not living in their bodies and I can't predict what exactly is going to happen. And I ask them to try and start the medications when they have time to spend, just in case they get that urgent bowel movement. The secretagogues of Linocletide and Prokinetide, they actually gave those in the morning. Is it half an hour before food? And so, that's the way it's recommended. But I ask patients to kind of see how their bodies respond to it and take it when their bodies best respond to it. Although, a lot of the over-the-counter medications we recommend to take in the evening.
Yeah, and precalpride is recommended to be taken after a meal. Remember, of course, lubiprostone, its association with nausea and meals. In terms of the timing, I think we all probably have a wide gamut of patients, but I'll have some patients who will come in and say, boy, that medicine works quick. Within 2 hours, I'm on the toilet and doing my business, and then I can move on with my life. And I say the same thing, figure out what works for you. I do have some patients, I rarely do this, but I'll tell them to take it at night. That's more often I'll do that in patients with diarrhea and we're trying to slow down their bowel habits, not so much with constipation where we're trying to accelerate them. The one caveat that I think is going to be very interesting is this new agent, tenapanor. Remember, this is a twice-a-day medicine, and it's trapping sodium in the colon. So there might be some variability with regards to food intake and how well it works for individual patients. And that'll be interesting to see how we figure that out as time goes on.
One little trick I also use with secretagogues that you can do is that if they're getting a lot of diarrhea, you can ask them to take a fiber tablet with just a little bit of water because the fiber can take up the excess water in the stool, and sometimes that works for some patients.
That's a great tip.
Quick yes or no. Any role for probiotics in chronic idiopathic constipation?
Not in my opinion.
Not in my opinion, but I have patients who swear by some probiotics.
And that's okay.
Next question. How long should these drugs be taken for? Is it these medications forever and ever?
Not necessarily. They have been shown to be effective long term. Again, you have to individualize approach. You will have patients who say, ask that exact question. What I do with many patients is I'll bargain with them and say, if we can get you normal, quote unquote normal, or not bothered or satisfied for 6 months, let's revisit that and we can stop it. And if your symptoms come back, then we know we've got a safety net, we can restart it. If your symptoms stay gone, and I have seen patients do this, I don't know why, I think they're retraining either their gut or their motility or their expectations, which is more likely, and their perceptions, then we don't restart. So I will bargain with them. I try not to use these medicines chronically if I don't have to, but in many patients you will have to do that.
Well, I kind of disagree. I think some patients will continue to need them, especially if they've had lifelong constipation. And what may actually end up happening is that they use them a couple of times a week.
Right. No, I don't think we're saying anything different. Absolutely, some patients are going to need chronic therapy. But if you are concerned about that or the patient's expressing concern, if it's working, it's not wrong to give them a trial of life, as I call it. Worst case scenario, you go right back on and it will work again.
Final question for you, Dr. Harris. How do you talk to female patients about the need for the digital rectal exam if they're culturally very timid? And you have 20 seconds.
I actually tell them the importance of it in terms of diagnosing a defecation disorder. And what I will do is I will be very careful with draping, and I'll also go through what I'm going to do before I even touch them.
And the other thing I do is I always have a female nurse in the room when I'm doing the examination.
I have less of a need for that.
Yeah, and it's important to ask about past experiences with trauma because you can set off some emotional distress, so be very sensitive to that as well.
Right.
There are 2 or 3 questions that we haven't addressed, such as, what do you do with excessive perineal descent, which I think goes beyond the ability to do that in the context of this symposium. But I'd like to thank you all for your participation and for your wonderful questions, and we trust that this has been a useful exercise for you. And just to remind you, to receive credit, CME or CE, you need to complete that post-test and evaluation online, and then click on the Request Credit tab to complete the process and print your certificate. Thank you very much, and have a good evening.
Thank you.